So chronic thromboembolic pulmonary hypertension is one of the few potentially curable areas of the pulmonary hypertension. Yet it remains under-recognized and frequently diagnosed late. Today's discussion focuses on how to suspect CTEPH early, how to diagnose it accurately, and how to choose the most appropriate treatment pathway. I will begin by sharing a clinical case and then move on to case-based discussions, which will be short just to kind of invite the panel thoughts. And then we will have structured panel discussion, which is organized into 5 focused rounds. All right, so next slide. All right, so she's a 31-year-old woman on oral contraceptive pills. She presented with progressive dyspnea over 3 weeks and found to be hypoxic. CTEPH showed extensive proximal pulmonary artery thrombus consistent with acute pulmonary embolism. Baseline echocardiography performed, which showed estimated pulmonary artery systolic pressures of around 85 with RV dilation and dysfunction. She was treated with apixaban for 3 months. Patient remained dyspneic. A follow-up echocardiography performed after 3 months. It showed estimated pulmonary artery systolic pressures of around 60 with RV dilation. In view of the persistent symptoms and consistent pH on the echo, we got a VQ scan ordered, which showed multiple mismatched perfusion defects suggestive of chronic thromboembolic pulmonary disease. So we got a CTEPH done. CTEPH was consistent with the signs of the chronic thromboembolic pulmonary disease, like webs and bands were seen in the proximal and the main pulmonary arteries. So we referred for the further evaluation. A right heart cath showed pre-capillary pH. A catheter PA-gram showed surgically accessible CTED. She underwent successful pulmonary end arteriectomy, and on 6 months of follow-up, she had persistent pH. So that was a pre-capillary pH. Consistent with persistent pH post-end arteriectomy. So this single case basically opens up a few clinical questions, which I will address to our panelists to invite their thoughts. So Dr. Jignesh, I'll start with you. This patient, at the time of the index acute pulmonary embolism, had markedly elevated pulmonary artery systolic pressures of around 86. Does it raise a bell?
So, yeah, considering this is the first episode of pulmonary embolism, probably, she did not have any past history of documented embolism. So, such a high pressure of, more than 70 or 80 usually indicates that probably patient might be having some underlying chronic vascular disease which was not diagnosed earlier. So any pressure more than 50 and at presentation more than 70 to 80 should raise a suspicion of underlying chronic vascular disease, like recurrent pulmonary embolism in the past, and we should rule out CTEPH, or we should just get a suspicion of CTEPH and then proceed for the investigation further.
Superb. So as he rightly put, that this patient has RV dysfunction and markedly elevated pressures of 86. So in acute pulmonary embolism...
I just have one question.
Yeah.
Was this patient thrombolized when he landed up in an acute trauma?
No. So all his NT-proBNPs and were normal. There was no hypotension, no shock, nothing. So this patient was in intermediate low risk.
But he was hypoxic. She was hypoxic.
Hypoxic.
So hypoxic with the normal cardiac markers, and today echo was normal.
Yeah.
Okay.
All right.
Just one question. So
sure.
Suppose just for discussion, suppose the cardiac markers were high, we put have thrombolized her at the right time, do everything right. Would we expect the chances of the chronicity of thromboembolic loads lesser in a thrombolized versus a non-thrombolized?
Here the question was basically whether patient is having already pre-existing.
No. My question is hypothetically, if we would have cardiac markers were rightfully thrombolized.
So theoretically, the chances are low, but in this case, at the index presentation, you already had severe pH. So I don't think thrombolizing chronic CTEPH leads to any long-term improvement. Yeah.
So great. Basically what Dr. Jignesh said, that if you're looking markedly elevated pulmonary pressures of more than 60, or if you're looking for RV dysfunction, or if there is an extensive proximal pulmonary artery thrombus, then we should look for acute on chronic vascular changes. So Dr. Weber, this patient had, despite 3 months of anticoagulation, this patient had persistent pH and persistent symptoms. So we ordered a VQ scan. Do you routinely do VQ scans in such patient, or do you think it is underutilized test?
Obviously underutilized, probably because we may not have so much centers to do it, and in Mumbai specifically, everything goes with the cost of the test and everything. But in such cases, we do push for a VQ mismatch. Obviously, that doesn't come as a first test. We would like to do out the CT chest, the lung function test, to rule out other causes of hypoxemia. And then, yes, one point in time, we will have to, because we have to offer some kind of long-term therapy for this patient.
Sure.
Actually, it should be done, VQ scan must be done, because it has a specificity as well as sensitivity more than 90%, and at least
Super.
it will give a negative predictive value that it is not there.
Yes, yes. Very rightly put by Dr. Ashutosh that, you know, normal VQ scan potentially rules out CTEPH. And it can pick up the distal peripheral disease more than the CTPA. I think the slides are dancing. So, yeah, I think everybody's hungry. So, all right. So my next question is to Dr. Caroline. Caroline, you know, at the start of acute PE, this patient was initiated on a direct oral anticoagulant. Do you think that after suspicion of CTEPH or after confirming CTEPH, would you like to switch this patient to a warfarin, or would you like to continue this to a DOAC?
Yes, most definitely. Once the patient is even suspected to have CTEPH, and then of course on confirmation, we have to convert from direct oral anticoagulants to warfarin therapy. Because nowadays, I mean, there are studies that are actually showing that even though the efficacy of both is the same, the efficacy of both the vitamin K antagonists as well as the DOACs are the same, but DOACs do cause new venous thromboembolisms to occur in the body. And CTEPH means you have to give lifelong anticoagulation. So that's why the moment you suspect, forget about once it's diagnosed, the moment you suspect, you have to shift over to vitamin K antagonists.
Great. So basically,
Indu, can I interrupt in between?
Yes,
Dr.
please.
Tala, this controversy regarding anticoagulation. What I know is, if the patient of CTEPH is diagnosed with antiphospholipid syndrome, that is the condition where you really need to go for the warfarin.
Yes.
Otherwise, you can continue. Is this
Yes.
controversy? Like, what do you want to say?
So, even in USA, despite these guidelines saying that you should use warfarin for CTEPH, we've used NOACs unless the patient has APLA. Then in that case, we use warfarin. We have not seen any untoward events happen even on NOAC. We have a pretty busy CTEPH practice, and we've not seen any bad.
Dr. Tala, even if it is triple positive, we can continue with DOAC? I mean, confirmed after 3 months,
Triple
APLA
positive for no. So in those cases,
Warfarin.
unequivocally
what, yeah.
warfarin.
Right. So what we have learned is APLA positive patients, we need to switch the patient to warfarin. Other than that, we can continue with the NOACs. All right, great. So, Dr. Caroline, this patient post-pulmonary end arteriectomy, in fact, I would also like to invite Dr. Neeraj Kamath on this. This patient had a persistent pH post-end arteriectomy. What do you think? What is the hemodynamic definition of persistent pH, and what should be a realistic hemodynamic target to achieve after the surgery?
I'll take that for Neeraj. So the success of PTE surgery has a lot to do with the surgical skills. For us as physicians, we just send them for a PTE surgery. We don't know what happens in the operating room. A successful PTE surgery, it results in nearly instant, meaning you will see pre and post surgery in the OT, you will see nearly 80% improvement in the PVR and the PA pressures right there on the table. If you are not seeing that, either the surgeon was not able to get all the thrombus load out, so there is incomplete removal, or there is, and this is more common, incomplete removal is more common, or there is probably another component, overlapping component for the significant pH. In terms of residual pH, there are, as far as I know, I don't think there are any cutoffs for residual pH in terms of PA pressures, but I please correct me if I'm wrong.
20 or 25? I read it in literature.
Mean artery more than 20, they said.
This is the latest. More than 20 is the latest.
No,
Previously
so
it used to be 25.
that's the definition for pH in general. We are asking a specific question about residual pH post CTEPH surgery. So I don't know if there's any defined. Normally, yes, sir. Normally, almost instantly, 90% goes down and PVR comes down, your mean PA pressures go down. In some cases, it takes about 4 to 6 weeks for it to completely come back to normal. Yeah.
Right, sir, but in this case, there is a data that approximately 35% patients, even after the surgery, they persist to have pH.
Correct. So in those cases, what we see is there is distal disease, which again I alluded to, that you cannot get everything out. So that's where the surgeons come into picture.
So here it's a lot of a gray zone actually when we say distal vasculopathy in addition to CTEPH. At the same time, there is a mechanical problem, and we all are aware that anything in the central or till segment 3 arteries, the surgeon is pretty confident of getting the load out. But it's actually what we see is getting into the right plane, and unfortunately, majority of the surgeons, when you're operating, you're doing it on a deep hypothermic circulatory arrest, wherein you're stopping the circulation to the whole body. So there is a hurry to finish the job than to do a complete job, because you have 20 minutes where you know that your brain will not get affected even if you're stopping the flows to 0. So just a minute. So in this hurry, you tend to miss out on the most distal branches. So if you see because we are doing transplants, if you go into the ISHLT guidelines, what they used to say about surgery only possible till segment 3, now they are saying you need to operate on almost all the patients of CTEPH, because even if you follow the Hippocratic oath, you don't give harm. Even if you are removing a lesser load, it's okay, but remove load because it's mechanical and it will give the patient some benefit, vis-a-vis not giving any benefit or not giving that option of surgery. But the harm is pulmonary hypertension, missing the right plane because everything looks white there. And sometimes we have seen preoperatively, when we know there is no major load in the central pulmonary artery and probably it is starting from the right lobar artery, and when we open, we see that there is no clot in the right lobar artery. Sure. But actually there is a plane there, and you just need to, it just comes with when you do more and more and more, you get into the right plane and you realize that I'm not sure at that point of time whether I have removed enough or not, but when you release the clamp, you realize that the PA pressures have come down and we have done a decent job. But the CT answers majority of the questions, how much the patient will get benefited, sure. Because we know the load is more in the major pulmonary arteries, sure. when it is in the major pulmonary arteries.
So
we'll move on.
Small clarification. Sure. So this surgery is an open surgery, it's a catheter-based surgery, how it is?
This is an open heart surgery.
Open heart surgery.
Yeah, pulmonary thromboendarterectomy is an open heart surgery where you have to put the patient not only on heart-lung machine, you have to reduce the temperature to 18 degrees centigrade, where you can stop the whole body circulation for 20 minutes at one. So what we normally do is, we stop for one side 20 minutes, we again start the circulation for 20 minutes where we get some time to take a short break, and then we go and do the other side. But majority of the surgeons try to do both the job in those 20 minutes, and there is a little bit of a messy thing.
Sure.
And if you go into the wrong plane, you know you are going to give pulmonary hemorrhage, and then so
the other
that's
complications
what makes it more.
basically. So instead of circling around the single case, let us move on to the structures, because there is shortage of time, so let's not, yeah. So we'll have 5 focused rounds basically. We have got the gist of the whole case. There is acute pulmonary embolism, incomplete resolution of the thrombus, and then we have got the CTEPH. We know the high pulmonary artery pressures raise the risk. We know that history of an acute PE raise the risk. You know, so these, we have got the gist. So now let's move on to the 5 focus rounds. Our round 1 will focus on how to suspect CTEPH early. Can we have Dr. Randeep Guleria, sir, and Dr. Madhukar also to join us? All right. So Dr. Jignesh, I'll start with you. What early clinical and echocardiographic red flags should raise the suspicion for CTEPH, particularly after an episode of acute pulmonary embolism?
Yeah, can you repeat the question, please?
Yes. So what are the red flags that you're looking for when you're suspecting CTEPH?
So yeah, at presentation, the pulmonary pressure is more than 70 to 80. That is one of the red flags. Then persistent symptoms, especially beyond the 3 months, the failure to come down to the functional baseline level, and the pH, even after 3 months, PASP remaining more than 50. So these are all red flags, and we should
Exercise limitation, exertional syncope,
syncopes and everything.
and any echo signs of RV dysfunction and pH that you want to mention?
Persistent RV dysfunction, RA dilatation, there is flattening of the septum, you know, there's strain on the RV, the height, anti-pro BNP, maybe TEPC and other parameters that cardiologists might
Right.
Yeah.
So we,
Yeah.
Because it's about acute pulmonary embolism. Again, I don't know how many of you are aware. We are, I think in COVID, majority of the pulmonologists have understood what is ECMO. But I think there is a very important role of ECMO even in acute pulmonary embolism, as it has a role in acute myocardial infarction. So the cardiologist does the PAMI, the catheter based will do the acute pulmonary embolism, but when we see majority of the patients, there is a hemodynamic compromise and a multi-organ issue already. So you need to have a ECMO team who can institute VV or VA ECMO to make sure the oxygenation is good, and the catheter-based doctor can take some time to do a good job. And I think I would like to know what is
But
your
sir, one doubt. I mean, when you're coming with such acute presentation of pulmonary embolism with hemodynamic instability.
Yes, so you can put a VA ECMO and they, at the same time do the catheter-based thrombosuction, thrombolysis, whatever you need to do.
At the
Because
same
then
time,
you know the
simultaneously.
hemodynamics are good and you can spend some time improving the clots and you keep the ECMO for 2 days and then you can wean off the ECMO.
So we'll come to the surgical part later. Let's focus on how to suspect it. So Dr. Weber, my next question is, when should imaging be repeated in the patients who continue to have persistent symptoms? What's the correct time?
So any episode after acute PE, we would like to have them on anticoagulants for at least 3 to 6 months. After 3 months, you can start evaluating them for breathlessness, hypoxemia and all. If it is out of proportion, definitely you got to investigate them further on with that.
So basically 3 months is the correct time when you should call the patient again, look for the clinical worsening of the symptoms, and imaging can be repeated early if the patient is deteriorating or if the echo signs are worsening. So the ideal approach should be an echo followed by a VQ scan. Dr. Madhukar or anybody from the panel, how do we differentiate post-pulmonary embolism syndrome from chronic thromboembolic pulmonary disease and CTEPH?
I think post-pulmonary embolism syndrome is an umbrella term. If after the pulmonary embolism, if the patient continues to have exercise limitation, then these are the patients who are termed as post-pulmonary embolism syndrome. And if these patients are so on imaging, the evidence of, either the band or slit, whatever you talked
VQ
about.
mismatch.
Yes, VQ mismatch. Without having pulmonary hypertension, then we call it CTEPD. And if the same patient goes on to develop pulmonary hypertension, we call it CTEPH. So why is it important? Because we really have to follow up the patient very closely who has post-pulmonary embolism syndrome. So,
Sure. So great. Dr. Talha, would you like to just mention, I mean, should we treat these CTED patients without resting pH? Should they be treated? Chronic thromboembolic pulmonary disease without resting
pulmonary
pH?
vasodilators.
No, surgically. They have
far,
got PA obstruction.
Yeah, so far what we know is there is no major benefit of treating these patients with a surgical intervention for these patients without evident pH on right heart catheterization.
Even if the, let's say the exercise pH or a CPAT shows circulatory limitation?
So in that case you can use pulmonary vasodilators. But if there is no significant pH, you will not really benefit. If there's no PVR, what are you going to,
I mean not with the vasodilators, but do we treat, Dr. Kamath? Have you done any
CTEPH
no?
without pH?
Without pH.
We haven't.
No? Okay.
Surgically we have not.
Yes,
Medically
surgically. Yeah, we are talking about surgical. Yeah.
Surgical or BPA intervention, anything?
No, BPA maybe in certain cases, but not surgery.
Sure.
The surgery is very involved. It matters. I mean, it's putting someone on
So
hypothermic
what the
arrest.
literature mention is, in selected patient with symptomatic pH, we either do a PA or a BPA depending on, if it is required.
Symptomatic
Very
pH.
selected, individualized
Symptomatic
decision.
pH.
Yes.
We are talking
Symptomatic.
about
CTEPH,
without
yeah.
pH.
Yeah.
Without pH, no surgical
Great.
intervention.
All right. So, Dr. Guleria, sir, any diagnostic pitfalls that commonly delay the diagnosis of CTEPH?
So I think very often the diagnosis gets missed because you are not suspecting it, and you are not evaluating a patient for CTEPH. I've had patients who've been diagnosed to have dyspnea for other causes and have not been evaluated. And when you do a VQ scan, you find out that there is evidence of CTEPH.
Yeah.
So I think a high index of suspicion is required if you have a clinical setting.
Most important, yeah. So many a times we label it as deconditioning or asthma or anxiety. So I think high index of suspicion is most important, or we are over relying on the CTPA, which can actually miss the distal peripheral disease. So VQ scan should be ordered. And mislabeling also.
So I've actually seen this very common. I don't know if this is common in other clinical practice, but CTPA being done, very clear webs and bands and peripheral pruning, but they have been missed. They have been called as,
yes.
They have just been called as normal PA, normal CT permeation. This is quite common. Even in big centers in Mumbai, Gujarat, we see a lot of these patients. So surprisingly, it's very common.
Yeah,
and obviously having VQ scans would really, help with that.
Yeah, Indu, I have a CT radiologist who believes that you can pick this up on a CTPA
Yes, it can definitely, but we need a
need to proceed
pH radiologist, actually, good pH radiologist. Amrish, can we have the slides, please? All right. So, Dr. Ashutosh, this question is for you. What does an elevated NT-proBNP signify in this context?
NT-proBNP elevation implies that there is a pressure on the heart. Now, it is progressing towards cardiac failure, a core pulmonary. So, RA dilatation or RV dilatation, that is what it predicts.
So great. I think, so elevated NT-proBNP basically correlates with the RV wall strain. And it's a really good prognostic marker. It helps in the baseline assessment as well as in the post-intervention follow-up. Right, Dr. Thala?
Absolutely.
Right. So, Dr. Caroline, which patient-related or disease-related risk factors increase the likelihood of developing a CTEPH?
Now, like for example, in the case that you discussed, the patient was already on oral contraceptives.
Right.
So that also, I mean, drug-related features like oral contraceptives, then even hypothyroid states and all that of the patient. Now, also keep in mind that it has also been discussed the entire morning about all the autoimmune features like APLA syndromes and all that. These all can keep producing new clots which ultimately then end up in developing CTEPH.
Yeah, so basically a lot of risk factors like polycythemia, essential thrombocythemia, we have splenectomy, APLA syndrome. Dr. Madhukar mentioned morning high doses of the thyroid replacement therapy. Dr. Guleria sir also mentioned about the same thing. So I think we have to look for the risk factors. Not necessarily every patient will have a history of acute PE. There could be a silent embolia which is going on.
So we do a full thrombophilia profile in all patients who come with CTEPH before we subject them to anything.
Sure. All right, so what we have learned so far is persistent symptoms should be looked for. Risk factors, as Dr. Caroline mentioned, CTEPH may occur without documented acute PE. A VQ scan is the preferred screening tool, and early suspicion changes the outcome. So let us now move on to the round 2. Now, this is the simplest diagnostic approach. You suspect, you screen, and then you confirm. This is the image. We have a CTEPH on the above panel, which shows normal pulmonary arteries, but there is a filling defect in one of the segmental arteries of the right middle lobe. Below panel, we have this ventilation perfusion scan, scintigraphy, which shows normal ventilation, and you have the perfusion defects bilaterally, which is seen. So mismatched perfusion defects is what we are looking for when we are seeing CTEPH. This is another image which shows below, if we start in the first, last row, we have the ventilation images and then the perfusion and then again ventilation and perfusion. So we can see the mismatched effects. There are darker areas and there are reduced blood flow in the lighter areas. So let us now move on to how to screen and confirm CTEPH by imaging. So Dr. Jignesh, why is VQ scan preferred as a first-line imaging in the suspected CTEPH?
So VQ scan has a highest sensitivity, close to 100%, so it does not miss any, even a distal peripheral defects. And it has been confirmed by ERS 2022 guidelines as a level 1 evidence. So
no contrast is required.
Yeah,
that is again
safe
one more.
also.
Yes.
And the CTEPH might sometimes rule out, miss the distal.
Yeah. Is perfusion scan only a reliable tool, or we need a ventilation perfusion scan? What do you think?
Yeah, both. I think VQ scan, both
We need a VQ
we
scan.
require that mismatch between the ventilation and
The key is
perfusion.
basically to look for the mismatch and not just the low perfusion. So, Dr. Weber, which CT features suggest chronic thromboembolic disease rather than acute PE?
So even before the CT, I think the word acute and chronic tells us many things. Acute will come with sudden symptoms, big presentations. Chronic would be low, hypoxemic, daily walking.
Sure.
So that is acute and chronic, but just if you look at CT perspective, so definitely in acute there will be the main arteries, main trunks which would be dilated, filled up, filling defects. In chronic we may have it normal. The peripheral part of it would be affected in the chronic part, where you might see some mosaic attenuation and effusion effects. While in acute they may or may not be. So in general.
So basically a lot of signs like webs, bands, ring-like stenosis, post-stenotic dilatation, we have mosaic attenuation, pruning of the peripheral vessels. I think we can pick up, and even if we don't pick up, I mean the radiologist doesn't pick up, and you are suspecting CTEPH, you have a history of PE, why don't you call up your radiologist and just ask them to look for the webs and the bands and ring-like stenosis, abrupt vessel cutoffs. I think we should make that attempt to confirm. All right, Dr. Madhukar, how should mismatched VQ defects be interpreted in the clinical practice?
Yeah, I think when we say mismatched, there are areas where ventilation is okay, but perfusion is not adequate. So with the preclinical probability of chronic thromboembolic disease, if you are doing VQ scan and it shows mismatched defect, it builds up to a level that the probability of CTEPH is very, very high, and then we should go on to do certain tests to confirm the presence of obstruction in pulmonary artery.
So what happens in parenchymal lung diseases? Would we get a mismatch or a matched defect?
There would be matched perfusion defect.
Super.
And matched perfusion defect wouldn't only occur with the parenchymal lung disease. 20% of the patients with idiopathic PAH will also have matched perfusion defect. So we should keep this in mind when we interpret the results of VQ scan.
So there is some difference. I mean, when we are looking for the CTEPH, we have this VQ mismatch which are wedge-shaped, they are sharp, segmental defects, multiple segmental defects are seen. When we are looking at the idiopathic PH, we have this speckled pattern which is patchy and ill-defined. So this is one difference, and again, the clinical things, and we have to correlate with everything. Great. So, all right, Dr. Caroline, would you like to take this question? When should a PA-gram be performed? Or Dr. Ashutosh, I mean, we have done a VQ scan. No, so basically, okay, I'll take this question. When should a catheter PA-gram be performed? Or Dr. Talha, would you like to take it?
When should a catheter
Catheter
PA
pulmonary
be performed?
angiography.
After a lung VQ scan without a CTPA.
Yeah. So we confirm, we do a VQ scan, we see a mismatched perfusion defects, we do a right heart cath, we confirm pH, and at the same time we do a catheter PA-gram to confirm. And how does it help, Dr. Talha?
So if you're doing the right heart cath with already a CTPA being done, I don't think it adds a lot more doing a catheter PA-gram. In the olden days where we did not have a good CT PA-gram, everyone at the time of right heart cath would get a PA-gram. And to know where the disease starts, you would see the levels, and actually that is what the surgeons were trained to look at initially. But in contemporary practice right now, we rarely do a catheter PA-gram. Most of the patients come to us with a CTPA. Our surgeons are happy. If we need to, we may repeat a CTPA in our hospital. But otherwise,
Maybe it helps when we are thinking about BPA or something
so that's
like that. For
later,
segmental
yeah,
and
so
later.
for that's later on.
Sure.
But if it's purely for PTE, it doesn't add much.
Sure. Thank you so much. Dr. Ashutosh or Dr. Neeraj Kamath, your opinion on this. How is operability for the pulmonary end arteriectomy assessed? I'll start with Dr. Ashutosh.
Actually, for operability, I think the lesion should be proximal, and there should be sufficient hypoxia to the patient to decide for operating. And there is a California classification also, which decides where is the embolus. They grade it from 0 to 4, I think, proximal, then they label it as lobar, segmental, subsegmental. So this helps to evaluate whether to operate.
So, Dr. Neeraj, does hemodynamics help? I mean, severity
So
of the
there
hemodynamics.
are four indications for surgery mainly. First is the chronicity, which is the symptoms. Patient is breathless. Second is right ventricular strain, high PA pressures or high PVR, and obviously a more centrally located load will get a better surgical outcome or a better prognostic curative surgery. The more distal the disease, actually nowadays, it's not that we cannot operate, because once you get into the right plane, you can really go up till the depth. Sometimes we can't see it, but because the thrombus load, we get it into the center, because if you see, all this load goes into the walls of the arteries. So once you get a plane proximally, you have to just respect the plane, and there is a beautiful Jamison forceps which we use, which is a sucker as well as a dissector. And we just need to go, and it's absolutely end-on view, but you just keep on, the circulation is 0, so there is no blood coming. So you tend to see a lot of things quite distally and try to get as much load as possible. And it comes really beautifully.
Dr. Neeraj, severe parenchymal lung disease, is it a contraindication or do we take this?
Absolute contraindication, and we need to rule out on the VQ scan that there is no parenchymal, additional parenchymal oxygenation, because then you are increasing the blood flow, but at the cost of no exchange. So then, I think that's the...
Great. Thank you so much, Dr. Neeraj. Caroline, what are the limitations of CTPA and VQ imaging in CTEPH?
So now when it comes to CTPA, like it was already mentioned, that you really need to have a very good radiologist to actually diagnose. You need to be able to appreciate all the pruning, the eccentric thrombi, any webs and all that. So the experience of a radiologist is very vital in CTPA. Now VQ, the limitation in VQ is that not many institutes in, I should say in whole of India actually have the this thing availability. And again, in that also you need experienced people, cost factor, all these things actually do play a role in our country in a situation like India.
So basically a VQ lacks anatomical detail, and a CTPA, yes, of course, the perfusion mapping is not done. So we right now have a dual energy. We don't have, but in the future probably a dual energy. CT would also have perfusion mapping. So both are complementary to each other. Great answer. Dr. Talha, this is for you. I think from morning, I think we're discussing this. When should CTEPH, cardiopulmonary exercise testing or a stress echocardiography be ordered in the suspected CTEPH?
So if the CTEPH is already confirmed, we don't really need to do any of these. If there is suspected CTEPH, but the echo is not showing significant PA pressures, then in those cases, and again, if the symptoms are more dynamic, at rest you may not have it. So in those cases, we may want to put them on a modified Bruce protocol on a treadmill test and do a stress echo. So far, I have not required the need to do a cardiopulmonary exercise test, but maybe very rare cases we've done a stress echo for suspected CTEPH.
Great. So this is a new addition in the 2022 ESC guidelines, basically, CPET indication. When we have an abnormal VQ scan, and then you have a resting pH which is normal, then you should subject this patient for a CPET to look for the circulatory limitation. And if these patients have circulatory limitation, then these patients have got, they're highly suggestive of chronic thromboembolic pulmonary disease. And then you should investigate further these patients. All right, so whatever we have learned so far is normal VQ scan excludes CTEPH. A CT and a VQ are complementary to each other. Angiography is a planning tool. It helps in the operability assessment and before the BPA planning. Operability definitely requires expertise like Dr. Neeraj Kamath. This is the diagnostic algorithm, and I was talking about the CPAT indication, which you can refer to. This CT was reported normal, but on scrutinizing further, we found a chronic web, which is pointed by the orange arrow. This is again a VQ lung scintigraphy showing a mismatched perfusion defect. Additional signs like mosaic attenuation and bronchial artery collaterals, which we can look for. This is a PA-gram showing pulmonary artery narrowing. We have the stenosis there on the right side and the abrupt vessel cutoff. I think we ourselves should look at these signs if you're suspecting CTEPH in your patients.
You see the upper arrow, if it is showing there, but actually it's
Abrupt.
starting from here.
Yeah. Right.
Which is very
Narrowing of the vessels, yeah. So this is another one showing webs and bands. You see the ring-like the bands which are seen, the yellow arrows. It's like bands, you know. Okay, let's move on to round 3, which is on treatment approaches in CTEPH. I think this will go back to Dr. Kamath. Sir, how do we decide suitability for a pulmonary end arteriectomy? Do you have a team of it? I mean, what is the proximal disease and what is the distal disease? Is there any diameter which you all look at?
No, I don't think there is anything like diameter or anything, but yeah, more proximal disease is what we are more interested in. Even though that it is a distal disease, we can still attempt it, but we need to tell the patient from beginning that we might not be able to get substantial load and be able to get a decrease in PVR or a decrease in PA pressures. I think we had only one patient in which we didn't get much load and we did not achieve much satisfactory decrease in PA pressures, but otherwise we've always chosen patients who have more of central and lobar pulmonary artery load.
Dr. Neeraj, are you aware anybody in India are doing balloon pulmonary angioplasty? At least in Bombay, if I may ask you.
So no one in Bombay. Only one person I know who's doing it is in NH
Sure.
Narayana in Bangalore. They are the only one. So when
So which is most difficult? It's the PA or the BPA?
So BPA has its own place. When I was in Pittsburgh, we did a few and then we stopped and then we started again because it is a very steep learning curve for a pulmonologist. For a cardiologist, it's a very steep learning curve. We lost a few patients because of devastating pulmonary hemorrhage. And so then we had to send our cardiologist back to Japan. They are the biggest group doing BPAs. He came back. And then we started the program again. Presently, we only consider BPA in patients who have very distal disease where the surgeons say, no, absolutely not, I'm not going to touch him. Or if they have residual pH and after a PTE surgery and the repeat CTPA still shows, persistent defects, especially a VQ scan that you do and it shows persistent mismatch defects, then in those cases you can target those chambers. Again, BPA is something that just one session is not enough. Sometimes you have to do repeated attempts at it, and as I told you, very steep learning curve. You only realize that after you've lost a couple of patients, unfortunately.
So great. I think what Dr. Talha mentioned is basically balloon pulmonary angioplasty is a catheter-directed technique. It is, we put the balloon and we dilate the obstructed vessels, and it's done in 4 to 6 sessions. Lot of complications, that's why it's, you have to look for lung perfusion injury happens, or a perfusion-induced hemoptysis or things like that. So yeah, it's a difficult procedure, and so is the pulmonary end arteriectomy.
Pulmonary endarterectomy, there are mainly two, apart from risk to life, but the two most common complications is one is pulmonary hemorrhage, and the second is right ventricular dysfunction. And for both, you need some sort of a mechanical circulatory support like ECMO, and we have our own protocol. So we had a few patients who had pulmonary hemorrhage, but then we just balloon dilated, we occluded that side of the lung, kept that patient on VA ECMO for the first 48 hours. We were not in a hurry to wean the ECMO. After 24, 48 hours, we opened up that segment of the lung, allowed the lung to improve. We converted the VA ECMO into a VV ECMO because the cardiac part was taken care in the first 48 to 72 hours. And then that patient, we kept her on tracheostomy, and almost on 7th day, we were able to successfully wean off the VV ECMO. So that's how a standard protocol is. There's nothing to worry about if there is pulmonary hemorrhage. You should be more aggressive in putting ECMO if need be. So that's what is the team's learning.
I have a small question.
Reperfusion injury, correct? Injury which is, right. Dr. Madhukar, what is the role of medical therapy in CTEPH management? We have soluble guanylate cyclase stimulator.
Yeah, we should first understand that this pulmonary endarterectomy is the curative therapy for, CTEPH. So wherever we are not able to offer curative therapy, the patient would require medical therapy. Perfect. So, for example, if a patient with pulmonary endarterectomy after this surgery have residual pH, you will give Riociguat. For example, if a patient is not a good surgical candidate, then also you will give the Riociguat.
Yes, sir.
If the disease is peripheral.
Not an interventional candidate too. Any hemodynamic, marker which suggests, before BPA planning, because the literature mentions the PVR of a particular number.
So there is some literature, again, as we head into the BPA world, it becomes more murkier, lesser number of people doing it, so lesser population. But there is some evidence coming from Japan that if it doesn't really benefit unless the PVR is high, unless the PVR, I think the cutoff they said was around 4 or 4.5. Yeah. So that is what they had recommended. Otherwise, I don't know if any big papers are showing that.
I think there is some consensus on that we should have a pre-surgical assessment for the residual pH in a patient. And this I do because this helped me to to have a dialogue with my patient that even after surgery, you might require lifelong therapy with the pulmonary vasodilator. And this is where I subject my patient for the right heart catheterization. If there is disproportionate rise in the pulmonary vascular resistance compared to the size of the clot, for example, if the clot is in the subsegment area and the PVR is 6, now these are the patients who are probably developed pulmonary vasculopathy, distal vasculopathy, and these are the patients even after surgery would require medical therapy.
No, so I feel you cannot accurately predict the load that the surgeons get off. Sometimes I tell Neeraj, itna nahi aayega, and he comes, he shows me these pictures, wonderful webs extending right till the periphery. So it's really hard. I don't know if there is any test to predict. Yes, we can make certain educated guesses, but we've been wrong. At least I would say 50% of the times we've been wrong. Itna nahi aayega and bahut aata hai, and it's really curative for the patient.
So Ashutosh, my next question is for you. What are the supportive therapies which are essential in the long-term management of CTEPH? Like we have been discussing since morning.
Actually, these patients required lifelong anticoagulation. Apart from that, they may require oxygenation or LTOT. And whenever they get symptomatic, that symptoms need to be addressed.
So diuretics basically for the right heart failure.
Yeah, definitely.
Any role of pulmonary rehab? Supervised exercise training, Dr. Jignesh?
Yeah, definitely.
Yeah.
All these patients
Should be subjected for
definitely subjected for
supervised exercise training. Great. Where is my slide? All right. So, Dr. Talha, how do we sequence this PA, BP, and medical therapy? And we have already discussed that considering REOC when the PVR is more than 4.
Right. So after pulmonary thromboembolic surgery, you give at least 3 to 4 months before considering. So if the patients are having persistent symptoms or the natriuretic peptides are high, echoes not showing resolution of pH, then in those cases we would do another right heart cath, PA-gram, and then consider for BPA, yes or no.
Right.
So at least 3 months on that.
So great. This is a nice illustrative figure which I liked. I mean, we have the macrovascular compartment which is seen on the imaging where we do the surgery and we do the intervention. And then you have the microvascular compartment with proximal, with the intimal thickening and proliferation. Because of the shear stress, there is increased blood flow to the non-obstructed vessels. And where this is the condition the medical therapy is given. So this is the treatment algorithm one can refer to. Dr. Talha, I mean, we have discussed these during, I think, Dr. Guleria sir's session. In a patient with systemic lupus erythematosus and antiphospholipid antibody positivity and suspected CTEPH, how should we diagnose this patient and what is the recommended long-term anticoagulation strategy?
I think we've already answered the second part.
Yeah.
If it's APLA positive, definitely warfarin. If for the first part, how does this overlap affect the
SLE
diagnostic
patient.
approach? Yeah. So basically SLE, antiphospholipid, and suspected CTEPH. So we need to know which is the main risk factor which is driving the phenotypic approach. So a VQ scan will be very, very helpful here in determining if the VQ scan is showing significant mismatch defects, then you know that is driving the pH. If the VQ scan is not, then we know, SLE, it's the CTD which is driving the pulmonary hypertension.
So, yeah, sir, Guleria,
So would you actually consider giving immunosuppressive therapy in these patients upfront? Because the issue would be what component is the dominant in terms of the vasculopathy or in terms of...
If the VQ scan shows large mismatch defects, then it's very clear. But if it's not, then definitely disease modifying therapy for the CTD.
So actually it's very easy. I mean, you have to look when there comes like a mixed phenotype, you have to look for the dominant phenotype which is ruling and then accordingly treat. So if you have a vascular obstruction, we do the operation after the accessibility, and if not, then you give the immunosuppressants.
But one thing is that for all these autoimmune diseases, it is, I mean, not just the pulmonary embolism or the CTEPH or anything. I mean, these patients, they actually have thrombocytopenia and all those other systemic involvement. So then I think in that case, you really have to give immunosuppressant therapy, because if you don't give immunosuppressant therapy, then the other systems also then flare up.
No, definitely. If there is an inflammatory predominant SLE, then you treat these patients.
So even the pulmonary part can have a vasculitic component. Yes. So you may treat the obstruction, but the vasculitis itself will need immunosuppressive therapy in the long run.
Yes.
So it's probably a combination of treatment, what you want to do first and what you want to follow it up with.
That too, I think maximum immunosuppression. Most of the times we give a low dose and we don't see the benefit. So I think maximum immunosuppression is the key. My last question is again for Dr. Talha. This is a gray zone basically. Are current pH guidelines adequate for managing the mixed phenotypes? And specifically, how should we manage these patients of HFpEF pH and coexisting CTEPH? And how should they be treated? I mean, right heart cath will show different pre and post capillary. So
right. So the current pH guidelines are very honest about it, and they say that in these overlapping phenotypes, there is no clear approach. You have to take each individual case as it comes, and take markers from each of your diagnostic tools, including imaging as well as your well-performed right heart catheterization and an echocardiogram to help you determine which is the dominant phenotype and to attack that dominant phenotype. CTEPH if CTEPH is the driving or the dominant factor with a combination of other things, and if the CTD is say something not like scleroderma, something else, which is not very aggressive on the other systems, then maybe we can, be more aggressive in offering a surgical option to them and hope for a better outcome. If it's a very significant CTD which is affecting, multi-systems, renal dysfunction like lupus, as Dr. Singh was mentioning, in India, we see a lot of lupus with early renal involvement, young patients to having a lot of cardiac involvement as well. In those cases, even if they have a CTEPH component, offering surgery to them may not really help.
Sure. Just for the benefit of audience, can you explain what is HFpEF pH on the right heart cath? How do you kind of do the fluid challenge?
So HFpEF pH is basically the group 2 pH, which is driving the pulmonary hypertension. So in those cases, so it's isolated post-capillary pH. In those patients, your wedge pressures will be high, your pulmonary capillary wedge pressure will be high, more than 15, and your pulmonary vascular resistance will be low. So will be your transpulmonary gradient. If we do a right heart catheterization and we are suspecting HFpEF related pH, and if we do the baseline right heart cath and we find that the PA pressures are only mildly elevated in the presence of a wedge pressure, which is sort of high normal range, 12, 14 or maybe 12 to 15 range. In those cases, we do a fluid challenge. The recommendation would be to do at least a 250 to 500 ml crystallod. I use just normal saline through the IJV, the sheath through which we are introducing the Swan gans through the side port, rapidly infuse 500 ml of normal saline over 10 minutes. And with the PA catheter in situ and measure the PA pressures and the pulmonary capillary wedge pressure. If the wedge pressure significantly rises, meaning if it goes above 18 to 20, then you know that there is a post-capillary component, and that's what's driving the PA pressure.
So Dr. Tala, I mean, after the fluid challenge, the pulmonary artery wedge pressure, let's say it's in the gray zone between 15 to 17, would you call it post-capillary or it's only more than 18?
So if it doesn't go up and the PA pressures are also remaining stable, then there is no significant post-capillary. However, if the wedge pressure doesn't go up and the PA pressures are still going up, then that means you're truly in the gray zone. Now you don't have an answer. In those cases, what you can do is exercise the patient. It is very difficult. The jugaad way of doing it is what I generally do is with the patient supine. We don't have a cycle supine ergometer here. We had that in Pittsburgh.
Leg raise.
Yeah, so what I do is give them 2 saline bags in the hand and have them exercise. That's what I do. When they lift the legs, they tend to, that tends to affect the venous return, and I've seen some of them even do a Valsalva while raising their legs. It's weird. So the pressures tend to fluctuate a lot, but this is the way that I do sometimes. Just give them 2 saline bags and do some kind of exercise and watch after 5 minutes. But these are not standardized protocols. These are not standardized protocols.
So nicely explained that this is a mixed phenotype, basically combined post and pre-capillary pH, and I'm sure HFpEF pH is not a contraindication for the surgery, right, Dr. Kamath?
No.
Right. Great. So my closing remarks are CTEPH is frequently missed but potentially curable. This is the only group of pH which is curative, and structured evaluation and referral are the key, and expert center management improves the outcome. Thank you so much to our panel.